patients, especially acute leukemia patients that have a really poor prognosis, and many of them deaths.
Yeah, it's but it's good that you don't have any active patients on your service at least.
Yeah.
Welcome everybody for joining the seminar. And thanks, Dr. Shadman.
Should I start, or I?
No, I think Dr. Yaghmaie will start with some introduction, and maybe Dr. Mousavi or others, and I'll introduce you. Then
Sure.
I'll go away, and Dr. Barkhordar will moderate the session.
Are you ready to start the session?
Dr. Yaghmaie, whenever you want to start, you can start. I start the recording.
Okay, can you hear me?
Yes, yes, we can hear you.
Okay, we can start. Okay, thank you everyone for joining the How I Treat program. I'm so honored to welcome you to the second session of the webinar, Acute GVHD Prevention and Treatment. I am Marjan Yaghmaie, Associate Professor of Medical Genetics at Tehran University of Medical Sciences and head of the leading house for Iran North America Academic Partnership, which has planned and organized this series of educational programs. This is a fantastic educational opportunity for Iranian hematologists and fellows to collaborate and share their experiences and learn from Iranian American expert physicians and scientists in the field of hematology from North America. This webinar was made possible with the great help of Dr. Maziar Shadman, Associate Professor of Medical Oncology at the University of Washington. I would like to express my special thanks to him. I also appreciate the Appraise-to-Raise team and the support of the Tehran University of Medical Sciences Vice Dean for Educational Affairs of International Campus. Here, I would like to ask Dr. Shadman to give an introduction on our program and introduce our invited speakers, Dr. Armin Rashidi, and then ask Dr. Barkhordar, our moderator, to welcome you and start the program. I also very welcome to Professor Qawamzadeh, Head of Iranian Society of Hematology and Oncology, and Dr. Mousavi, Head of Oncology, Hematology, and Cell Therapy Research Institute for joining us. I should also mention that the certificate of attendance for this webinar will be awarded to the participants who will be present for more than half the time of this session. Thank you very much, everyone. Dr. Shadman, please.
Thank you. Can you hear me well? Can you hear me?
Yes, we can hear
Yes.
you.
Okay. Thank you very much, Dr. Yaghmaie. And I would like to thank Tehran University for providing the platform for this series. This will be the first clinical presentation, as almost a month ago we started with the hematopathology talk, and I think we are all, and I can speak on behalf of my colleagues here, very excited, not just for this series, but hopefully for many more upcoming programs and collaborations with you. The intent here is to cover different topics in heme malignancies by focusing on the big picture and really trying not to get lost in details. As we know, this field is really has been really exploding with all the details and the new treatments. I just wanted to take the opportunity and thank my colleagues in Iran, we really do have a lot of respect for what you do. You treat the same patients that we treat here, but you don't have access to many drugs that we have access to and resources that we have. And unfortunately, in many cases, your patients can't afford many of the treatments that you would like to use. And you still manage to take care of them, including our family and relatives in Iran. So I really appreciate what you do. And we really hope for this to be an interactive session. We would like to learn from you. So please keep it interactive, and hopefully we can have a very meaningful series here. With that, it's my pleasure to introduce my great friend and colleague, Dr. Armin Rashidi, who is an assistant professor of medicine, Division of Hematology and Oncology and Transplant at the University of Minnesota. Dr. Rashidi is a graduate of Tehran University. He then earned his PhD from the Newcastle University in England, did a postdoc fellowship in the University of Arizona, and finished his internal medicine residency at Eastern Virginia Medical School. He then did his fellowship for hematology and oncology at the Washington University at St. Louis, and then joined the faculty at the University of Minnesota as an assistant professor with a focus on GVHD and leukemias. And for those who know the transplant field, he's really a superstar in this area with many publications and contributions and awards. And I'm really honored to have him as the first speaker for the acute GVHD prevention and treatment. Dr. Barkhordar will be moderating this session with Dr. Rashidi. Thank you very much.
Hello, welcome everybody. I welcome to everyone that participant, every participant that to this hematologic, to this how I treat hematologic malignancy entitled Acute GVHD Treatment and Prevention. I'm Dr. Barkhordar, hematologist and oncologist working at Transplant Research Center of Shariati Hospital. I'll be modulating this presentation today. First of all, I'd like to thank Dr. Yaghmaie, Dr. Rashidi, and the Appraise-to-Raise team for organizing this scientific webinar. Regarding the certificate of participant of this webinar, it's necessary to fill out the online form that my colleague will send its link in the chat box. Participants who have a question or have a comment can do it by tap the hand raising icon or type their question in the relevant box. And now it's a great pleasure to invite Professor Qawamzadeh to join me in this webinar. Professor Qawamzadeh. Professor Qawamzadeh, can you hear me?
Hear me now? Hello? Hello?
Yeah, hello. Hello, Dr. Qawamzadeh.
Can you hear me?
Yes, yes.
Hello, hello everybody. That is very interesting session and complicated session for this complete session that we are speaking about this situation, particularly for Iran, because we are starting this bone marrow transplantation in many centers. They need more education and more information, particularly with international center to perform new treatment and new approach for GVH, particularly because this is infection and GVH is very complicated and high mortality for the transplantation. As you know, that is my experience for GVH is I focused on the last time as I worked in the University of Tehran, particularly cellular therapy for GVH. With mesenchymal cellular therapy for the GVH for lung and GVH for skin and GVH for liver. But I don't know what is your experience about this situation. Except for the medical treatment, we started with cellular therapy. We have also in last time for COVID-19, we have treated also with NK cell for the COVID, because Dr. Shademan asked about the COVID, and yes, we also treated some patient with COVID with mesenchymal cell. We had very good result for the COVID, particularly with lung involvement. I give you to start it, and Dr. Rashidi to tell us about experience in Minnesota.
Thank you, Professor Qawamzadeh. And now I invite Dr. Musavi to join us in this webinar. Dr. Musavi.
Hello. Thank you everybody for your joining this webinar. thank you from Dr. Scheidemann, my friend, for organization of this seminar. Thank you, Dr. Rashidi, for your presentation about acute GVHD prevention and treatment. And thank you, Dr. Yaghmaie and Dr. Barkhordar, my friends and my colleagues in our institute. I ask from my teacher, Professor Ghagamzadeh, for leading this webinar. Thank you very much.
Thank you, Dr. Mousavi. And now it's a great pleasure to invite Dr. Rashidi for a start his lecture. Thank you, Dr. Rashidi.
Yes, thank you very much for the kind and thorough introduction. Pleasure to be giving this seminar. I'm going to start with a couple of questions, and Dr. Yaghmaie or Barkhordar, if you could give me some clue about some of these questions so I understand the audience better and I can figure out how to best deliver this talk. I have no conflicts of interest, but some disclosures are here that I need some help with. I really don't know how BMT used to be done in Iran when I was a student there until 2006, because I wanted to be a nephrologist at the time. And so I had no idea. Also neighboring countries, and I still don't know how BMT is done in Iran and neighboring countries, because I haven't been back home since I left in 2009. So if I, name some approaches or drugs or generic names or things that are not familiar, just interrupt me and let me know. And I really don't know all the concerns and challenges and issues that you are dealing with, when treating these patients and taking care of complications of transplant. So I want to make sure this talk is helpful for all of us. I learn something from you, you learn something from me. So if there are aspects that you think are obvious and you don't want me to focus on them, no problem. Just let me know that, we know this, forget about it, move on to something else. Or if there are things that you think, oh, this is a little bit, too fast, slow down, or, tell us about this one or that one, or this was a patient I had, which was very challenging. How would you have treated this one? Just let me know. This is going to be interactive. It's really more or less a, kind of a casual exchange of information and experience. All of us will learn from each other. And, ask questions. Don't need to wait until the end. I really don't want it to be anything formal. Ask about anything you want. If I don't know them, if it's difficult, I'll ask Maziar to help with the difficult questions. And so you're going to hear a lot of I don't knows when you ask me questions, but that's okay. Okay, and last disclosure, I don't treat children. So I have no idea how much of what I say is going to be applicable to pediatric patients. If some of you are pediatricians, make sure you check the literature or ask someone who knows about children. I really don't. Okay, so this is a real case. My own patient who was at the time a 75-year-old man with AML, which had transformed from primary myelofibrosis. And his treatment is listed here. First, he got Vyxeos with no response. And then we treated him with a combination of decitabine plus venetoclax plus ruxolitinib. And as you know, decitabine venetoclax, was becoming a popular combination for newly diagnosed unfit patients with AML or those who are relapse refractory. This is about maybe a year and a half ago. So it was getting popular, but it hasn't been combined with ruxolitinib at the time. It made a lot of sense to do it because the patient had myelofibrosis. So ruxolitinib was already approved, and expecting some cytopenias, we combined all three of them, and it worked. So he achieved a complete remission with the second attempt at induction. And while he was getting the chemotherapy, so the first round, about a month, and then the second round, I think he got 2 cycles of this. So about 3 months, we had time to look for donors, and we found a good 8 out of 8 matched unrelated donor, and he didn't have a matched sibling. So this was our best choice at the time. And we took him to an allogeneic transplant using that matched unrelated donor. It's not a universal rule or anything to not myeloablate patients at a certain age threshold, but here in Minnesota, we don't do myeloablation over the age of 55. So it's a consensus. You could argue that for a fit, patients, 57 is not old. So you can, if there are not much comorbidity, you can myeloablate them. Many centers do, we don't. So we did this reduced intensity conditioning with fludarabine, cyclophosphamide, and TBI low dose. And we added ATG to this conditioning, again, not necessarily required, but as I will talk in a future slide, for unrelated donor, probably better to include something more than what you do for sibling or other types of transplant because of the risk of GVHD. People have tried T-cell depleted graft, ATG, alemtuzumab or Kempath, post-transplant cytoxan, something extra to take care of the alloreactive T cells to minimize ATG. The reason being, with unrelated donors, you are looking at more major or minor histocompatibility mismatches. So this is how we did it with flu, Cy, TBI, ATG, and his GVHD prophylaxis after transplant consisted of tacrolimus and mycophenolate mofetil MMF. He did fine overall. I saw him about maybe twice a week for the first perhaps month, and then once a week, sometimes twice a week for the second month. And around 2 months after transplant, his hemoglobin dropped and platelets dropped, and he became a little bit more hypertensive, and some acute kidney injury, LDH went up, and I think there were some schistocytes in his peripheral blood, although I don't remember exactly, but the picture was clearly consistent with a low-grade microangiopathic hemolytic anemia due to most likely tacrolimus. So he was still early on. We didn't want to switch his GVHD prophylaxis completely. I just gently, very cautiously reduced his tacro level to and kept it around probably more close to 5 than 10. 10 was our goal around, in the first month, and then I dropped it a little bit lower for 5 and 6. And his kidney function was not great. His creatinine, fluctuated around maybe 1.8 or so, but these are usually, if they don't get more severe, usually reversible. You can just keep going for a little more while until they are out of the danger period. And then once you start tapering the tacro, the kidney function resolves to baseline or almost baseline. So I kind of just played with it a little bit and kept him there for another month, but possibly because of reducing the dose and level, or maybe for other reasons, around day 80, he developed nausea, vomiting, and diarrhea, and I was seeing him about once a week still at that point. So, he started to lose weight, and there was some watery diarrhea. We ruled out infection causes and other common causes of GI disturbances. And I'm going to stop here and then present some slides. We'll come back to this case in a little bit. So these are CIBMTR summary slides for, I think, 2020 that show most common causes of death in adults who receive an allogeneic transplant. This is a summary of 2018 through 2019 that was published in 2020. So we're going to show one slide per donor type. So match-related donors are shown here. And these summary slides are, by the way, great. If you, I think probably the best consensus resource you can find for free online are these CIBMTR summary slides that are updated on an annual, I think annual or maybe biannual basis. Really nice statistics, very reliable, nicely audited frequently. So I definitely encourage, you know, the fellows and residents who are interested in using this. Nonetheless, so in the left pie chart, you're looking at causes of death within the first 100 days after transplant. And what you are seeing here is that, you know, there are a lot of relapses that cause death, you know, about a third of them, but infections are common, and then organ failure for various reasons. But GVHD is about 13%, so not negligible. This is not the incidence of GVHD. Remember, this is among all deaths within the first 100 days after transplant. 13% of them was caused by GVHD. So pretty fatal condition, as you can see here. And beyond 100 days in these match-related donors, it's again 13%. And then the prime disease, relapse of the primary disease starts to come up because most of these relapses are happening between 3 months and 1 year or 2 years. So not a big surprise there, but shows that GVHD is fatal, is a potentially fatal condition. And then when you go to unrelated donors, the percentage goes up a little bit. So it's, I was honestly expecting much higher, something like maybe 20% or so, 25%, but this is the data. So 16% of deaths were caused by GVHD in the first 100 days, and beyond 100 days on the right side, 11% of the deaths are caused by GVHD. A lot of them are by the relapse of leukemia or whatever primary disease the patient had. So 53%. This is good data to share with patients. Half of patients who get an unrelated donor transplant and die, death is because of relapse, not because of what we do to them with transplant. And then this is data from haploidentical transplant, haploidentical relatives. And so for this one, you see the percent death due to GVHD is lower than anything else. So only 8% fatal GVHD is happening, but you know, in the first 100 days and also in subsequent weeks and months. But you notice there are 60% relapse-related deaths in after day 100, which is a big number, and I will get to it in another slide. And shortly after transplant, so in the left pie chart again, a third of deaths are because of organ injury. That's a lot. So a third of deaths are, you know, kidney failure, graft rejection, CNS problems, perhaps. It's not broken down, so I can't tell you what exactly constitutes these organ failures, but it's substantial, a third of the deaths. Now, just a few words on pathogenesis of acute GVHD, because this is very complicated and evolving field, and I think we only know and see the tip of the iceberg. There is a lot more to be known, and from a practical perspective, I'm not sure if all the details, mechanistic details, are essential to define, to know the diagnosis and define the treatment for the patient, but it's still good to know what's going on, what causes this. So with your transplant conditioning, you are damaging the epithelial tissues that have a rapid turnover, including the epithelial layer of the gut. And once the intestinal tract is damaged, two things happen. There are stuff that leak out of these dying cells into the subepithelial layer, and also because the barrier between the lumen of the gut and the inside of the body is broken, all the microbes and microbial antigens that are in the lumen can now more freely translocate through this damaged gut barrier and reach the immune system that's lying right underneath this damaged epithelium, and then further down in the mesenteric lymph nodes, and finally in the blood. When these epithelial cells are damaged, things like ATP, uric acid, and other molecules come out. And those are, because they are caused by damage to a living cell, those are called damage-associated molecular patterns, or DAMPs. And when the microbial antigens come in, those are pathogen-associated molecular patterns like LPS or flagellin, peptidoglycans, and all of those things that are associated with microbes. Now, you're causing this damage, and these molecules are coming in, and you're infusing the graft. The graft goes in with all the donor-derived myeloid and lymphoid cells that are expanding. They see these antigens, new antigens, that are presented on recipient antigen-presenting cells, in particular, some of the dendritic cells. And so these cells present the antigen to donor T cells, and the donor T cells get activated, they expand in the colon, and they start to secrete cytokines such as GM-CSF, but also a whole lot of other cytokines listed here. Those cytokines will then activate donor-derived dendritic cells or antigen-presenting cells, as opposed to the original recipient antigen-presenting cells. And these dendritic cells are extremely potent. They will pick up the antigens that are host-derived, and they are considered neoantigens for the donor, for obvious reasons. And then the donor T cells will nicely, react to these neoantigens presented by donor-derived dendritic cells. They expand in the mesenteric lymph nodes. They are then attracted to the host epithelium, and they start damaging the gut, and that becomes GVHD of the gut. So a little bit harder to explain this pattern in skin and perhaps liver GVHD, but more or less the same mechanisms and pathways you can imagine working in the liver, maybe less in the skin, because we don't know how much damage we cause with conditioning to the epithelium of the skin necessarily, and do the microbes really contribute to the GVHD in skin? It's not known, but this is the current model. Now, graft versus host is two things. It's graft versus host, a good part and a bad part. Obviously, in the lymph nodes and in the bone marrow, we want to have graft versus host effect, because this is what makes the graft engraft, and it gives us the graft versus tumor, or graft versus leukemia disease, graft versus lymphoma, not disease, but graft versus leukemia effect, or graft versus tumor or lymphoma effect. So we do want a reaction between the donor of the graft and the host, because that's the whole reason we are doing this transplant. But if the graft attacks the normal tissues of the host, that becomes GVHD, and it's bad. We want to prevent it. Most common is in the skin, but it's the least serious. Hard to lose a patient to skin GVHD, although definitely, you can see generalized rashes that ulcerate and get infected and lead to death. And then gut, lower and upper, is the most serious one. Particularly lower GI GVHD is the most deadly. So that's why you see usually, whenever you see a trial in GVHD, your first question is, did it include enough patients with lower GI GVHD? Because if it was mostly skin, it was mostly upper GI, patients usually don't die with these things. And so good outcomes in those trials should be treated with caution. could you apply the same principles to someone who has a more severe lower GI GVHD? So always something important to check in trials and papers. Liver GVHD, it can definitely happen, and it still happens, but with the current regimens and approaches and supportive care, it's become the least common. I don't know for sure in Iran how often you see liver GVHD, but I think probably in a typical center here, it's something like 5%, maybe less than 5%. It's pretty rare to see liver GVHD. One little hint about GVHD of the liver is that almost always the gut is involved. The intestinal GVHD is usually concurrently present. Unclear why, but probably because those antigens that I described, they travel from the lumen of the gut through the portal circulation and they end up in the liver. So if for some, again, it's a hypothesis really, maybe some discussion around it, but it might be true that when there is inflammation in the liver, it probably means it started from the gut in a lot of cases. Now, it's been discussed for decades that a little bit of GVHD may be good because it tends to be associated with a little bit more graft versus tumor or leukemia effect. And this is probably particularly true for chronic GVHD rather than acute GVHD. So you might see less relapse of the underlying condition with chronic GVHD. Very little known about such an association acute GVHD, and I personally think that acute GVHD doesn't reduce relapse. It's just bad by nature. It's bad. There is nothing good about it. Nonetheless, it's still a little bit of a debate in the field. And even if there was a little bit of association between acute GVHD and lower relapse rate, it's hard to predict or dose your acute GVHD. You can't titrate the patient such that they get only a little bit of acute GVHD. You could lose the patient to severe liver or gut GVHD because you weren't careful enough about GVHD prevention or prompt treatment of it. So because we can't engineer the system, it's best to prevent it effectively and not try to play it too smart. Now, acute GVHD is a risk factor for chronic GVHD because of the damage that the same T cells that cause acute GVHD also cause to the thymic epithelium and the tissue. And thymic tissue damage is a known mechanism for chronic GVHD. So another reason to not let acute GVHD happen. But what are the risk factors for acute GVHD? And if you have questions, just feel to interrupt me. I don't see the questions once I'm in this full screen mode. So if one of the moderators could unmute and just ask questions if there is something in the chat box. But obviously, if you do inadequate prophylaxis, that's an obvious risk factor for acute GVHD. The more HLA mismatch or minor histocompatibility mismatch you have, the higher the risk of acute GVHD. More intense conditioning regimens, particularly high dose TBI, so 13 or more grays of TBI, are these are high risk factors for acute GVHD, mostly because of the damage that they cause to the gut. I think it's pretty known that for that to be the mechanism. And then if you are using haploidentical transplant, that's another good question. I don't know if you are doing haplotransplants, but if you are older donors cause more GVHD. It's true in all types of transplant perhaps, but particularly in haplo, I think there is really good data to suggest you shouldn't use a donor older than age of 45 if you can afford that. So younger donors always better than that. And then unrelated versus related, it's a known risk factor for acute GVHD. And if you use peripheral blood versus bone marrow because of the larger number of T cells you infuse, and also the repertoire is different, So peripheral blood is a risk factor for GVHD. Now, how to prevent it? There are a lot of options, and really all of them are good. It's just a matter of style that some centers and some physicians pick a certain regimen and use it. A different combination is used in other centers. And because overall transplant is a rare procedure, if you consider all diseases in humans, we're dealing with a tiny population in our field. So doing a randomized trial to compare every 2 regimen is impossible. So some of these have been compared head to head, but most of these are just single arm studies or retrospective reviews or things like that. So it's really hard to say this combination is better than that one. You have to consider patients' preferences, how often can you monitor the levels, which drug is available, what other medications they are on that could interact, comorbidities that could be specific, could be specifically aggravated by side effects of one class of drugs. So I don't think there is any good or bad, with a few exceptions. So the classes are these calcineurin inhibitors, tacrolimus and cyclosporin. The issues are, you have to monitor the levels. It's not like warfarin that once the patient is stabilized on a diet and on a good level, you just check them once a month or every 6 months, or don't even check that. It's not like that. So the level has to be monitored because it just physiologically can go up and down, and it can be dangerous. So it goes up, you can get acute kidney injury, headaches, tremor, microangiopathic hemolytic anemia. It doesn't have to be related to a high level, but it's sometimes associated with that. And the other inconvenience with this class of drugs is that you can't stop it short. You have to keep going for several months. Again, no real good or bad length of time or recommended length of time to continue these for. I've seen places that go for up to a year, and sometime, between maybe 3 to 6 months post-transplant, they start to gently taper it. And other centers like us, for example, we start tapering these drugs at 3 months, and we finish them by 6 months. So over about 10 to 12 weeks, we taper them. Anything you pick is good, but I wouldn't taper it in less than 3 months. I think it would be just too aggressive. So let it go for a few months, and then, then taper it slowly. mTOR inhibitors, sirolimus is the most common drug used. And again, it needs level monitoring, probably less than calcineurin inhibitors. So maybe a little bit more convenient, but you run into issues of hypertriglyceridemia, which could be a problem. Definitely pancreatitis has happened due to very high triglycerides due to sirolimus. So, check a level maybe once a month or every 3 weeks or so. And then if it's high, you don't have to stop the sirolimus. Actually treat the hypertriglycerides with fibrate or something, and patients will do fine. But they can get, acneic rash on their face, and, weight gain and metabolic syndrome. So there is some inconvenience with sirolimus, not the most common drug to use. And if you combine it with a calcineurin inhibitor, you are increasing the risk of microangiopathic hemolytic anemia. There is some evidence that it's a very effective GVHD preventative medication regimen, but you need to be aware of, these unexplained drops in platelets, and quickly check your LDH and get a smear and make sure you're not getting into AKIs with microangiopathy. And MMF, it's another very good drug. We use it very commonly here. And the nice thing about MMF is it can be given for as short as just 1 month. In fact, I think in most US centers, it stopped around day 30, day 35. So that's the beauty of the drug. It doesn't need level monitoring. You just do it for a month and you stop it. These are large pills. At least what we get here are really big pills. So kind of hard on patients sometimes, and there are several pills a day. It has known GI toxicity, and most importantly, if someone is on MMF and they develop diarrhea and you suspect gut GVHD and you do a sigmoidoscopy or colonoscopy, you biopsy, you can find a lot of findings that could confuse you as GVHD, and it could be all related to MMF toxicity. So if you do a colonoscopy and you find GVHD findings, always call pathology and say, oh, by the way, the patient is on MMF. Could it be MMF toxicity? And it's just, I found it very difficult for pathologists to sometimes distinguish between the two. There are some, I think, specific features that helps them to pick one or other, but it's important for them to know that the patient is on MMF. What else? So methotrexate is another beautiful drug. I think it's short. You just give it for 3 or 4 days, depending on what regimen you pick, and by day 10, 11, you're done with that. And it's very effective in just bringing down the T cells and preventing GVHD. You're combining, obviously, with something, you don't give it as single agent. And the 2 problems with this drug are mouth mucositis and hepatotoxicity. So the way to decide on each of those 3 or 4 days to give or not give methotrexate is by examining the mouth and looking at the bilirubin. So based on the severity of mouth sores, if any, and bilirubin levels, you can skip the 4th day or the 3rd day or any one of those, or just give it. But it does need examining the mouth and knowing the bilirubin. And then ursodiol, that's the urideoxycholic acid. That is an option to prevent liver GVHD. It's not universally used. I don't actually know if there was ever a randomized trial comparing it to placebo. And Maziar might know this, but you know, many centers use ursodiol after transplant for 2 months, 3 months, something like that, to prevent GVHD. We use it here in Minnesota. It's a safe drug. That's the nice thing. It doesn't interact. It's really easy. If the patient can take a couple of pills, the extra pills a day, I think it's a nice option to have. Knowing how bad liver GVHD is, even if it has only 5% effect, I think it's worth trying. And most recent option, which I think has really revolutionized the field of transplant, probably the most recent revolution in the field after a long time, is post-transplant cyclophosphamide, which I will get to in a minute. So the European blood and marrow transplant community has a consensus, like a guideline or recommendation for prophylaxis for the world to really follow. And these are, I only put the 3 guidelines that are categorized as consensus category 1. And as you know, this means there are some randomized trials that showed superiority of these approaches over others, as opposed to category 2 and 3, which get kind of more of a soft call. These ones are really based on solid, good evidence. And these are, I think, the most widely practiced regimens based on these guidelines too, updated most recently in 2020. So they say for matched donors, methotrexate and a calcineurin inhibitor is the option, is a good or maybe the best option. So I think it's a really good recommendation. If you give myeloablative conditioning, include methotrexate. There is very good data on this as well. So this is number 2. And then for matched unrelated donors, this is what I was referring to in my 3rd or 4th slide, that they recommend include ATG. I think they recommend actually rabbit ATG in your conditioning regimen because of that extra risk of GVHD that you're seeing with matched unrelated. Other options, as I mentioned, are alemtuzumab, T-cell depletion. Again, I don't know what you usually use, but ATG is something that we also use at our center. Okay, and finally, this really amazing thing that I think changed the whole field dramatically some years ago is post-transplant cyclophosphamide. So what this plot is, did I forget to put the citation here? Maybe, let me see. Yeah, this is the plot, the graph I picked from Blood and Marrow Transplant Journal that was a report of, I think, Hopkins and Seattle that first tried this regimen in patients and was published in the journal. I forgot to put the citation here, but the way this is done is you give your transplant conditioning. I mean, it doesn't have to be fludarabine, Cytoxan, TBI, but this is how it was done, and it's still the most popular way of doing this. So this is the reduced intensity platform, where you give just 20 centigrays of TBI and then standard Cytoxan, standard fludarabine. And then -1, things finish. You infuse the graft on day 0, and then GCSF starts. And on day 5, you start the MMF and tacrolimus. And right before you do that, so day 3 and 4, you give the 50 milligram per kg per day of Cytoxan. And so in this first trial, one group gave it only on day 3, and then the other group gave it on days 3 and 4. And these days, I think almost everyone who's using this platform is giving it on days 3 and 4. And then you do the MMF for about a month, 35 days, 30 days or so. This is, again, the most common way of doing this. And tacro, you go for about 3 months or so, full dose, keeping the patients therapeutic, and then you slowly taper them over the next 3 months, and you finish off with this whole thing by 6 months after transplant. Now, what does PT-Cy or post-transplant Cytoxan do that made it such a popular and effective and revolutionizing approach? Well, this somehow preferentially attacks the expanding alloreactive donor T cells. It eliminates some of them and suppresses some of them. Not clear yet what exactly and how exactly it does it, but that seems to be the way it works. And so it limits acute and chronic GVHD very effectively. There is this ongoing debate that it might increase relapse. I don't think the field has concluded that yet, but it's a question mark. Definitely with this approach, you'll see more viral reactivations, perhaps more of other infections as well. Hemorrhagic cystitis definitely happens. You need to hydrate and give Mesta and the good supportive care with high-dose Cytoxan. So I think seeing hematuria, bladder spasms, those are relatively common. I don't know what percent, but maybe 20%, 30% of, maybe a little bit less, 10%, 15% experience that. But definitely do your surveillance for CMV, EBV, HHV6 if you can. Viral reactivations are very common with this. Now, so I talked about the risks and benefits. Which one outweighs? Definitely the benefit outweighs. So if there is a situation that post-transplant Cytoxan, you can do it safely, it makes sense, and I will talk about when it makes sense to do it. I think benefits outweigh the risk for sure, and it's justified. We don't really know if it increases relapse. It's still debatable, I think. But why is it so important practically? It's because it makes haploidentical transplant possible. It makes haplotransplant more feasible and safer. You could do haplotransplants using the Chinese platform or the older Italian platform. You use the T-cell depletion, give a lot of ATG before transplant. There are various ways to do that, but I think PT-Cy is the most popular one. Because you can do it safely, you can do a haplotransplant safely using this approach, your possible donor pool expands dramatically. So this is what makes universal donor availability, because if you don't have a matched sibling, and for whatever reason you can't find an unrelated donor in the registry, you are stuck with either a cord blood, which has limited availability and is expensive, or haplo, which most patients have, and it's cheap and quick. So haplo transplant, I definitely recommend having it in your repertoire. Now, a little bit about definitions. So we have acute GVHD and chronic GVHD. Obviously, so I should give a historical background here that it used to be that if GVHD was before day 100, you would call it acute. If it was after day 100, you would call it chronic. That has died. This is no longer the way to practice. So it's clinical features. You find the clinical features regardless of the day you define acute or chronic GVHD. Time doesn't matter for the most part. But what this table shows is that you need clinical features of acute GVHD to call it acute GVHD. Kind of obvious. But you also need the presence of chronic GVHD features to call it chronic GVHD. Now, acute GVHD can happen before day 100, then you call it classic acute GVHD, and this is usually in myeloablative transplants that happen earlier, close to day 30, 45. Or acute GVHD can happen after day 100, and you call it late onset. But you distinguish it from chronic GVHD because there are clinical features of acute GVHD in acute GVHD, and they're absent in chronic GVHD. So what if a patient has features of acute GVHD, but also has features of chronic GVHD? Doesn't matter what time, then you call it overlap. So the terminology makes a lot of sense. The bottom line here is that, oh, and by the way, in classic chronic GVHD, you don't find acute GVHD features. So, it makes a lot of sense. I don't think there is anything difficult or magic about this chart, but the bottom line is that don't think about time when you are diagnosed, where you're trying to distinguish between acute and chronic. And it's important because the treatments are not the same. So go with the clinical features. Now, there is this hyperacute GVHD, which is rare. It's really rare these days, maybe once a year or 2 years or something. It can happen sometimes. And the definition is 7 to 14 days usually after transplant. I think it's almost always a generalized rash, fevers. It's more of a cytokine release picture, hypotension, chills. And if that happens, you usually treat it. Actually, you can do things like cytokine blockage, IL-6 blockage, or even steroids if it's severe enough. But for acute GVHD, if you do a myeloablative regimen, the median time to onset is something like 30 to 45 days. It's early. And that's another reason to see patients at least once a week, if not twice. And with reduced intensity transplant, it's kind of a delayed onset usually, around 100 days, 90 days, 80 days. But it can definitely happen earlier too, or later. Now, I mentioned it's mainly a clinical diagnosis. Biopsy not necessary. It helps, but not essential. If you have a good clinical sense that there is nothing else going on, it's got to be GVHD, you can start treatment, and then if you change your mind, you just stop the steroids or the rest of the treatment. Now, I'm going to give you a few hints about different organ involvement that could help in your clinical practice. The skin GVHD, I think, is the one with most differential. So starting from engraftment syndrome, which is usually rash and a little bit of fever, maybe some diarrhea, fluid retention, anasarca type of thing, confusion, sleepiness, those things, to viral rashes, which are mobiliform rashes and kind of difficult to distinguish. Drug rashes sometimes can be confused, and all other differentials of rash are there. But if the rash is only on the face, it's usually not acute GVHD. So just something that you can use as a guideline. Again, it's not guaranteed. It can still be acute GVHD. It could expand next day and involve the arms or the torso. But if it stays on the face, usually it doesn't. It's not GVHD. Now, I told you about MMF toxicity that can be confused with intestinal GVHD, definitely something that happens in practice. And C. diff. C. diff, absolutely a requirement to rule out before you call someone acute GVHD. I don't know how long the test takes there, but we usually get it same day or next day. So you haven't lost an window of opportunity to give patients their GVHD treatment. You just wait 12 hours, 24 hours, you get the C. diff test back. And if it's negative, you say, okay, well, it's probably GVHD. Let's go ahead with treatment. Now, with liver GVHD, almost always lower GI is involved. In other words, there is diarrhea. And another little clue here is if the abnormality in LFTs is only ALT and AST, usually not acute GVHD. You need alk-phos and bilirubin elevation, and it's progressive. It doesn't stay there for a week. If it's GVHD, it's going to get worse and worse and worse no matter what you do until you start them on real GVHD treatment. All right, I'm sure you know the staging and grading. The older way of doing this, Glucksberg, is still fine, but what you're seeing here is the consensus, the CIBMTR staging and grading and classification, which is what most places are doing. Most trials are using this, and I think it is standard of care. I think everyone should follow this one. I will spend only a minute on this, but you stage it based on organ involvement, and then you use this result to grade, because the stage doesn't matter. At the end of the day, you want to know, is it grade A, B, C, or D, or 1, 2, 3, and 4? That's what makes the severe versus non-severe GVHD. Severe being grade 3 to 4 or C to D, and mild or non-severe being A to B. So you have to stage them, and skin involvement, skin staging is based on what percent of the body surface area is involved, and liver is based on bilirubin. Gut is lower intestinal here. If the patient is inpatient or outpatient, you can apply it and you just figure out how much diarrhea the patient has. And if there is severe abdominal pain or ileus, it automatically becomes stage 4. So don't look, this is sometimes missed. If there is not much diarrhea, maybe there is severe ileus or severe abdominal pain, it automatically makes it a stage 4, i.e. bad GVHD grade 4. And then you just plug your information from this chart into this chart and see what grade the patient is, and really that's it. Okay, so my patient, if you remember, had nausea, vomiting, diarrhea, and I think it was clear that he didn't have anything else going on. I ruled out C. diff. We did what we call an enteric panel, which looks for Salmonella, Shigella, some viruses, common infectious causes of GI gastroenteritis, and there was nothing. So I made a clinical diagnosis of grade 3 acute gut GVHD, and we wanted to start him on standard prednisone, which, as I will be talking about, is 2 milligrams per kg per day, 1.5 to 2 milligrams. But he refused because he previously at some point had a lot of, I think, irritation and anxiety with prednisone, and he just didn't want to use it. So this pushed me out of the book, because the book says give prednisone for frontline treatment of GVHD. And so, well, what should you do then? If the patient refuses, no textbook can help in that situation. Now, so we're going to move away from that patient again, and I'll get back to him. So if the patient is already off prophylaxis, it's a different scenario than if they are still on GVHD prophylaxis. For example, Tacro is still full dose, or it's not full dose, you're tapering it, but the level is still detectable. So there is a little bit of immune suppression still going on. If they are not off, well, if they are still on prophylaxis, make sure you make it therapeutic. So increase the TAPRO, increase the sirolimus, whatever they are on, make it strictly therapeutic in the range, and then start the new GVHD treatment. But if they are off prophylaxis completely, for example, you've tapered them, they're 7 months out or 8 months out, and clearly there is GVHD despite time, then no need to restart that older medication. Instead, leave it be and start the real GVHD treatment, which is this. So for stage 1 skin, so a tiny rash, or up to 15-20% or so of the skin area, topical potent steroids. Usually we use triamcinolone 0.1%. You can do twice or 3 times a day and keep doing it. No need to add anything else to it. Just keep doing it until the rash goes away completely. And then, it's a harmless medicine for the most part. Just continue for another couple of weeks and then you can taper or just stop. It's not a big deal, really. Well, if you're lucky and it's just a stage 1 or 2 skin GVHD, perfect. But if it's anything else, usually topical treatment doesn't work. It's not enough. You definitely still use your topical treatment, but add the standard frontline treatment, which is prednisone 2 mg per kg per day, or 60 mg per meter squared per day, or equivalent if the patient cannot have oral intake. You want to do methylprednisolone or Dex or anything. Again, not a guideline exactly, but you could do it in split doses for about a week or 2. And then afterwards, you can consolidate them into just 1 dose per day, however many pills it is. And then you keep going full dose until they are in a complete response for all GVHDs. All organs need to be in a complete remission. And then you start thinking about taper. If you do it faster, more likely than not, the patient will flare. And then even if you go back to the original dose, it often doesn't work. So don't cut it short. We usually here, as I mentioned, we do 2 weeks, and if it works within a week. So we know the patient is in a CR or PR, and then we can, if it's good enough, if it's a nice CR, all symptoms have resolved, rash has disappeared, diarrhea is gone, bilirubin is normal, then we usually taper it over the next 8 weeks. Again, this is not really a guideline. You could do it longer, maybe a little shorter, but probably not much shorter than this. Oral budesonide or beclomethasone for upper GI GVHD. So these are non-absorbable, largely non-absorbable oral steroids, which help. I think there is at least 1 randomized trial. Maziar can correct me, but I think it was from Seattle actually. The beclomethasone needs to be compounded by the pharmacy. Oral budesonide is an already available pill that it might work for upper GI GVHD. The nice thing is these are harmless. They might be a little expensive, but they are harmless. So you might get 5% absorption, but it doesn't really matter because often you're giving them high-dose steroids anyway. So this just acts locally on the epithelium of the gut. So that's something to consider. And this is important. Reassess the patient daily, if at all possible. Otherwise, every other day, I think it's really needed, because if you miss progressive or refractory GVHD, you might miss the patient completely, because particularly with GI, lower GI, the diarrhea becomes overwhelming and can easily kill the patient. Whatever you do, definitely you need to reassess physically at 5 and 7 days, because that's where the definition of refractory disease comes. If you don't see them, you're not going to even be able to define refractory disease. So 5 days and 7 days to see if there is response or if there is progression. Now, this is a meta-analysis of all randomized trials that compared standard frontline high-dose steroids for acute GVHD versus steroids plus something else. So we call it steroids plus placebo or steroids plus second agent. This is the comparison. And what you're looking at in these plots is the sum or the aggregate result from these 4 trials that made this comparison. And anything that stands to the left of this, no effect bar or line, favors placebo. That means steroids alone. Anything that goes to the right means it favors adding a second agent. And you know, this is a very important question. Can we escalate immune suppression, add something to our steroids to make sure everyone responds, to make sure no one progresses? Can we do that? So this was the question that these trials asked. And so if you look at complete response to this, to whatever treatment, at 2 weeks, there was no advantage to adding a second agent. You know, it overlaps with 1. 1 is no effect. 4 weeks later, and remember, response at 4 weeks is the most common standard to define response to acute GVHD treatment in trials and standard of care. So, you know, if you want to say this treatment is more successful than that, you need to show that there is more CR with that first approach at 4 weeks after starting treatment. So this is not related to transplant, obviously. This is after starting treatment. Now, CR at 4 weeks, absolutely no difference between the groups. CR at 6 weeks, no difference between the 2 groups. How about survival? Survival at 3 months. Why survival? Because if patients don't respond to steroids, a lot of them die, probably more than half die. So refractory steroid refractory GVHD is fatal, often fatal. So that's why response and survival are often hand in hand in acute GVHD. Now, very interesting. If you escalate immune suppression, overall survival actually drops. That's why with steroids alone, so you know, this aggregate sum favors placebo when it comes to 3-month survival, showing that adding a second agent wasn't a good idea overall. And at 1 year, you know, it overlaps a little bit with 1, but you can almost guarantee that these patients are dying more if they get a second agent. So this sum shows that we are favoring steroids alone plus, you know, placebo. So what's the conclusion? Increasing immune suppression for frontline beyond steroids is not good. At least as of today, we don't have a treatment that we can safely add to frontline steroids, get a better response, and not lose the patient. Now, you know, all that, you know, there are problems with steroids. So first, response isn't great. We get about 50%, so half of patients, you know, have a response 28 days after starting steroids. Another 10 to 20% are a partial response, but partial response isn't good. Because imagine if the diarrhea continues, you know, it's a problem. You know, it's poor quality of life. It's danger in electrolytes and, you know, infections, and you have to keep immune suppressing them for a long time. So it's asking for more and more trouble. We really want a complete response to anything in GVHD, in acute GVHD, not a partial response. And another problem is, even though half of patients are in a CR at day 28, many of them are not durable. They just flare up as soon as you start to taper, or as soon as you stop, or even if you don't do that, they still flare up on full dose steroids in another month. And as I mentioned, refractoriness to steroids is frequently fatal. Especially infections and fungal, and particularly fungal infections. These are common complications when someone is transplanted. You're keeping them in immune suppression and high dose steroids. We do see occasional DKAs, believe it or not, on high dose steroids. I'm sure you do too. Muscle loss, deconditioning, poor quality of life, debilitation. weakness, AVMs, avascular necrosis, frailty. So it's not a subtle COPD exacerbation that you treat with steroids. It's a big deal. So because of this, people have thought about using and finding a steroid-sparing agent. Can we completely abandon steroids for frontline and use something as a replacement? Something that gives us at least the same efficacy in response, but doesn't cause quite as much toxicity. And this is the trial that was done. So this was a large multi-center randomized trial comparing standard prednisone versus sirolimus for frontline treatment of Minnesota standard risk acute GVHD. Well, you can see we are comparing steroids versus a non-steroid agent with the goal of getting the same efficacy but less toxicity. And in this trial, you know, as a first trial like this, it's always a concern that should we include really high-risk patients, those with high-stage GI or liver GVHD? Is it safe? Is it ethical to do that? And the conclusion before the decision, before the trial, was that we should just use this first for standard risk. And what is standard risk? We didn't talk about standard risk. For that, to be clear, you need to look at this web page. So if you go to this web page, it gets you here, which is a newer way of you know, staging and grading acute GVHD. It's called Minnesota grading. It was developed here several years ago. And you just put the skin criteria, intestinal, liver, and upper GI. And then you click enter. Enter is somewhere down here. And then it tells you standard risk or high risk. There is no low risk in this. So if the patient was standard risk, they were eligible and they got randomized. So the prednisone arm got standard treatment. The sirolimus arm got a bolus 6 milligram of sirolimus, and then they were kept therapeutic afterwards for, I think, 8 weeks, if I remember correctly, 56 days or so. Actually, they were tapered for until 56 days. So they could start tapering, I think, as soon as the best response was accomplished. You know, what happens was everything was the same between the two arms, except you got fewer toxicities with sirolimus and more with prednisone. Let me push this banner behind. Okay, so overall survival the same. Steroid dose, obviously, in patients who got sirolimus was significantly lower, no surprise there. Although this means something. If someone was on sirolimus and switched to prednisone because they didn't respond, they could have been exposed to some steroids. This shows that it didn't happen very often, because otherwise the steroid dose in both groups would have been relatively high, but it wasn't. So clearly, it is a steroid-sparing agent. And you know, less hyperglycemia in the sirolimus in the sirolimus group, and what else? This one shows serious infection was a little bit less common in sirolimus. It didn't reach statistical significance, but it's reasonable to assume this is a true trend, and in a larger trial it might have been significant. Now, day 28 overall response, so that's complete response or partial response, was 65% in steroids. So everything is steroid versus sirolimus. They correspond. So 65% with steroids, 73% with sirolimus. And this was not significant. It's really not a real finding there, the difference. And one thing that's very highly debated is that the number of patients with lower GI involvement which is usually the most severe form of GVHD, was small. So only about 8% of patients had that. And that's less than what we see in real-world clinical practice. So this means less than 1.5 liters of diarrhea or 5 to 7 bowel movements per day. So this is a potential concern, that did the trial have enough of the real-world GVHD patient, a standard, typical patient with GVHD, or was it more, did it more favor lower risk patients? And that is the concern, that maybe in a more real-world typical patient, sirolimus is not equivalent or better than steroids. So this is an approach that's available. And obviously, for a really low-risk patient, you have skin only or grade 1, stage 1 GI or 2 GI, someone who you feel comfortable, even if you do this sirolimus and they don't respond well, nothing's going to happen. It's not that severe. You have another opportunity to switch to steroids or something. It's an option. You might get a good response. I've definitely had good success, but remember to use selected patients, not everyone. Okay, so my patient had a clinical diagnosis of grade 3 acute gut GVHD. He refused steroids, and we were out of the textbook. And so what I did was, because he was still on Tacro, we increased the Tacro, and his kidney function interestingly tolerated it this time. And I added sirolimus. This paper I showed hadn't been published at the time, but we knew this was an option. We could do it. What else could I have done? So I added the sirolimus, and his microangiopathy didn't get worse, but he didn't respond. He didn't respond at all. His diarrhea got worse. I think he developed a rash, actually. Nausea, vomiting was bad. And so what to do next? Now we are getting into this area that there is very little evidence until most recently. The treatment of steroid refractory disease was the most frustrating, most disappointing, the worst nightmare that a BMT physician had, because it's hard. We lose most of our patients. It was almost a death sentence to have steroid refractory acute GVHD. Until ruxolitinib or Jakafi was FDA approved for this indication. I don't know if this drug is available in Iran, but I'm going to show the results, the main ideas and the results nonetheless. It's a JAK1 and 2 inhibitor, which is immune suppressive. It really prevents T cells from attack and other immune cells as well, very immune suppressive. You could start with 5 milligrams twice daily in these steroid refractory cases if you want to be gentle. I usually do 5, or you could go more aggressive based on another trial that I will show you, and that's 10 milligrams twice daily. Most, if not all, patients will develop thrombocytopenia. A lot will develop neutropenia. Anemia is almost universal. So you need to watch them closely, transfuse them aggressively, and titrate. If the platelets drop under 25 or 50 or so, you can't do 10 milligrams twice daily. It's too much. You have to go down. And if it's single-digit platelets, you probably have to stop it. It's too much. But the most important thing that I need to emphasize is that if the patient gets a response and you want to taper it, don't taper it fast. If you taper fast, they can die with a withdrawal syndrome that's been seen in mice and in people. It could be a very stormy withdrawal and quickly lead to death. So do it over several months, not weeks. So this is the biggest trial and the highest level of evidence that we have for ruxolitinib. It was published in New England Journal of Medicine last year, very nicely done. A multi-center randomized clinical trial, phase 3. And it's interesting to see they screened 620 patients, and half of them were not eligible. That shows how bad these steroid refractory patients can be. A lot of them, were infected. I suppose a lot of them were infected. They were so cytopenic that they just could not get any ruxolitinib safely. So even the first 2 boxes already show how bad of a condition we are dealing with. But the 300 or so patients were randomized 1-to-1 between ruxolitinib versus physician's choice. And the physician could choose between 9 common drugs. And I forgot to show the common drugs in actually any of these slides, but common drugs that are used for secondary treatment are ATG, infliximab, mycophenolate is used sometimes, photophoresis, mesenchymal stem cells. What else? There are various cytokine blocking agents that you could use for this. I mean, the problem is the response you get from most of them is pretty low, and some of them are very difficult to do. For example, photophoresis is really difficult. It's not easy to do. It needs a dedicated line, and skin gets infected. Imagine the skin is already in a bad ulcerated situation, and you want to put a dedicated line into it. So these are difficult and not very effective so far. But the doctor could pick between any of these choices, and 50 of them or so crossed over to the ruxolitinib arm after day 28. And for those, eventually 150 were included in analysis in each arm. It's a really good paper. I encourage everyone to read it. And what you see is something significantly better than anything else in the ruxolitinib arm. So you got 62% overall response at day 28, and a third of these patients were in a complete response. Another third almost were in a partial response. And this was approximately twice higher than the control group that got one of the physician choices. So that's that, and it wasn't greatly durable, but it wasn't too bad compared to standard of care, which was only 20% at day 56 versus 40%. So again, twice better durability. I think there is the full half of the glass is that this drug works. Drug works really good. 60% response in steroid refractory disease was unheard of before this, and it is relatively durable. It's better than anything else we have. But the empty half of the glass is that there is still so much room to improve. So we are 2 months through this treatment, and already 40% of patients have lost the response. So they're going to die because we don't have anything there. And that's the sad part of the story. So this is not the end. Okay. Now, percent of patients who lost their response was higher in the control group. You could guess this from the previous slide versus ruxolitinib. And as I mentioned, refractoriness in GVHD usually means mortality. So beautiful gap between the GVHD failure-free survival of the two groups. Ruxolitinib really standing out in this comparison. You see how few of the control group are alive after 8 to 10 months. That's really bad. Okay, common toxicities are neutropenia, but particularly thrombocytopenia and anemia. Most, if not all, patients are going to develop these, so be careful with these. Use growth factors liberally. They are at such a high risk for infection. Definitely use prophylactic antibiotics. Cover mold. Don't do fluconazole. If you can do voriconazole or posaconazole, use that, because Aspergillus mucor, these are so common in these patients. Do surveillance, regular surveillance for CMV. I do it every week. Every week I test for CMV, and every 2 weeks or so I test for EBV in all patients who are on ruxolitinib, like without exception. Very important. One of my colleagues believes, who's an expert in ruxolitinib, believes it makes patients skid, like severe combined immunodeficiency. Like they are completely depleted of their immunity. Use your topical, the typical regimen to use for prophylaxis is acyclovir or valacyclovir, whichever you have. And then one of the potent azoles usually, definitely cover for PCP, PJP. And, consider using antibacterials. I think most physicians use it. Usually if fluoroquinolone, Cipro or Levaquin is a good option, levofloxacin is a good option. Penicillin VK is perfectly fine. As you know, in chronic GVHD is a standard treatment. I would recommend covering them for antibacterials until they come off their ruxolitinib. Aggressively treat all infections, don't let it go. You could even do surveillance blood cultures every couple of weeks and see them frequently. It usually takes several months to taper. Again, just don't rush the taper of ruxolitinib. It can go very wrong. So my patient, so he didn't respond. And then in the absence of any other good option, I mean, I could use one of those common, 9 common things, but I decided not to. And we added ruxolitinib. So it was tacrolimus, sirolimus, ruxolitinib. Such a heavy immunosuppressive regimen, but he was on board with this. He was, young and in good shape and excellent follow-up, good compliance. And I did everything for supportive care. Acyclovir, voriconazole, Bactrim, trimethoprim, sulfamethoxazole, levofloxacin for coverage. I saw him frequently. Next day, as soon as I started ruxolitinib, his diarrhea slowed down, and the following day it resolved. It's amazing how quickly the drug works in some patients. And I know this was the drug that worked because he already had been on tacro and sirolimus with no response. So there's no doubt that it was a ruxolitinib effect, not a delayed effect of those other 2 drugs. And then the question was, well, how to taper? He was on full dose tacro, full dose sirolimus, full dose ruxolitinib. He went into a nice remission. And I think 2 weeks or so later, I talked to him about the taper. So there is no guideline really, but I strongly suggest that you don't taper the ruxolitinib first, because this is the most effective drug. You should get rid of your less effective drugs first and then go towards Rux. So I stopped his tacro probably maybe over a month or so. And then sirolimus, I think I cut it down over maybe another month. And then 2 or 3 months later, I tapered his ruxolitinib over about maybe 4 months. So very slowly, I tapered him. And just a couple of weeks ago, when I saw him, he was completely off ruxolitinib, off immune suppression. This process took about 8 to 9 months. So you should be very patient with that. Okay. So in conclusion, prevent GVHD effectively. Don't try to have a little bit of GVHD. You cannot engineer this system. Don't let GVHD happen. Just prevent it. That's the message for today. Diagnose it proactively, aggressively. It's not self-limited. You can't wait and hope for it to get better. You have to treat it promptly. As soon as you ruled out alternative diagnosis, or you are in the process of ruling it out, give your steroids. And if things change, you can stop it. You can then switch to treatment of alternative diagnosis. Biopsy is not necessary. It often helps, but don't delay treatment to see the result of biopsy next week. Steroids are still the standard frontline therapy. Sirolimus is an option for select cases with less severe, probably less GI involvement. Follow the patient closely to assess response. Diagnose steroid refractory disease early, treat it promptly, use prophylactic antibiotics, do infectious surveillance because these patients can be infected and die. Ruxolitinib should be second-line treatment if available. Otherwise, use the best treatment you have. It's effective even when there is a lot of diarrhea. A lot of physicians are worried that, well, what if the patient doesn't absorb? It comes in and goes out. Well, it doesn't happen. I don't have a good explanation why, but you saw my patient, and there are so many similar patients that respond within a day or 2 despite diarrhea. Taper slowly, watch out for flare and subsequent chronic GVHD. Now, this is a conclusion that's not in any textbook, but I'm out of time. Do I have another 5 minutes to cover this, or should I stop? Maziar or Dr. Barkhordar, do I have another couple of minutes?
Thank you, Dr. Rashidi. We have a number of questions.
Sure.
The first question is, what's the cutoff platelet count for starting the ruxolitinib?
What's the cutoff? Oh, platelet count.
Cutoff platelet, yes.
Yeah, over 50, I started very comfortably. Over 25, I probably do maybe 5 milligram daily or 5 milligram twice daily. Or over 100, definitely, don't even worry about it. My thrombocytopenia is not a problem. Less than 10, I wouldn't do it. It's too dangerous.
Thank you. The other question comes from Dr. Mirhosseini. He asked about the gradual discontinuation of steroid in the treatment of acute GVHD after achievement of complete response. Is it possible to taper prednisolone more rapidly after 2 weeks of full dose treatment due to side effects with the addition of the other agents?
Yeah, you could. I mean, it's always a balance. And, this last slide was supposed to actually cover a question like that, always patient-specific factors guide your treatment. It's a risk you are taking. They are in a complete remission, but they have a lot of side effects. You want to drop the dose faster for various reasons. If there is accelerated hypertension due to steroids, or there is psychosis with a suicide attempt, obviously, there are things that override the textbook recommendation. Definitely, yeah, it happens. You can taper faster. Use your clinical judgment. There is nothing magic about the duration of taper or the method you taper. Patient-specific factors come first.
Thank you. The other question from Dr. Rashidi, what is the dose for acyclovir? Usually you use covering CMV for covering the CMV. As far as I know, it's now very effective. It's not very effective in CMV prophylaxis.
Yeah, that is correct. I usually do 400 twice a day to cover just HSV, really. If you want to cover the varicella, you could do twice as much. Either 400 4 times daily or 800 twice a day. Or you can do valacyclovir for 1 gram twice a day, or sometimes 2 grams twice a day to really cover that. But you're correct. None of these are really effective CMV prophylaxis. So people have tried, the valganciclovir, Valcite, lower dose or 450 twice a day to have a little bit of CMV coverage, but it causes thrombocytopenia and neutropenia, and it can overlap with the toxicity of ruxolitinib and GVHD itself. So there is no good answer. I mean, the newer drugs like letermovir and other CMV prophylaxis, I don't think they are available in Iran, but yeah, I don't have a great answer to this.
Okay, thank you. And the last question, do you use novel approach that aren't approved yet, like sitagliptin for treatment of GVHD outside of clinical trial?
Yeah, that's a very interesting paper, wasn't it? It was, I think, a letter in New England Journal of Medicine. I've never used it. We haven't used it in our center. But, again, something in this slide is creativity. If you are stuck, you don't have anything, you're losing the patient, what can you do? You just use what you have and what makes sense clinically. As long as the patient understands you are taking a risk, you are going outside of the standard of care, you can you can use it. It just takes a good and honest discussion with the patient. What we did in, what I did in one of my patients was, we gave them potato starch So potato starch is available everywhere. It's cheap, and it's based on an active trial right now. We don't know the results, but we know in mice it worked. We know in smaller scale studies it worked in humans. It makes biological sense to protect the gut microbiota and use the natural, health of the body to fight this complication. It's safe for sure. No one's going to have a big complication from potato starch. And, you can just find a typical dose and frequency of giving them starch. So these are kind of creative solutions when you don't have anything better. Yeah.
Thank you. Professor Ghabamzadeh has a question. Professor Ghabamzadeh, please. Your phone is off, Dr. Ghabamzadeh. You are mute.
Yeah, I don't have the voice.
I can't unmute Professor Ghabamzadeh.
Sorry, Professor Ghabamzadeh, I'm sending the request to unmute yourself. Please accept this request.
Mm-hmm. I think the problem isn't correct.
No, unfortunately, he's mute.
Okay. Thank you. Thank you, Dr. Rashidi, for your excellent and practical lecture.
Sorry, Dr. Barkhordar, one of our
Yeah.
participants has raised the hand.
Okay. Could you unmute him?
Yes, I'm sending the
Hello,
request.
tell me now. Hello.
Oh, okay. Professor
Hello,
Ghabamzadeh.
Yeah, Dr. Rashidi, thank you very much for nice presentation and very long presentation also. That is yet for information for you. That is that in Iran we have never used TBI. Therefore, we have less GVH in Iran. Second, population in Iran is young. Therefore, we have less GVH also in Iran. And that is the problem is also this is you have more haploidentical, more unrelated. We have had match related transplantation, but we have also done many 140, 150. Perhaps Dr. Barkhordar know better than me the number. We have done the haploidentical, but we have done also unrelated. The transplantation that in last few years we stopped to do cord blood. There's very few cord blood we have done. Later on, after haploidentical is as effective as haplo is effective as match related. Therefore, we have changed to haplo, not unrelated. Unrelated, that is cost very, very high for the population in Iran, and that is connection with other countries very, very confusing and very difficult to contact the other countries. We have done also unrelated, about 140, 130. We get unrelated from America, from every country from the world, But fortunately, then Iran, we have now about 20 centers for transplantation. And that is very young, very interested, very enthusiastic to do the transplantation. And that is, then they have to do perhaps two doctors, perhaps they have to do many transplantation for many diseases, not just for you in Minnesota, you have just for the GVH or for acute leukemia. We have to do change perhaps for every disease. Somebody have to be responsible for perhaps for one diseases, not for two diseases. But we have not enough doctor for transplantation till now. But now this is increased the number. That is therefore is for your information. That is here is the number for transplantation increased. Just in my center, I was there. I'm not there. We have done over 6,000 transplantation in this center, and that is yet per year. The transplantation is more than 1,200 all together to centers. You know, in countrysides in Tehran, and that is for your. We have that is my impact. That was you have not informed about the transplantation in Iran. That is the Dr. Yaghmaie had to inform you before, I think, before your presentation. That was nice. Thank you. That was really nice. And we have we hope we have the contact together with many centers in Iran, and you can. That is your originally Iranian. You know, perhaps you are in Tehran University, and that would be nice to contact with our people in Iran and to cooperate also. That is your transplantation for thalassemia. We have done 900 transplantation for thalassemia in Iran. You know, that is second number, high number in Iran. That is the peripheral transplantation, the first transplantation for peripheral in Iran. That is, we have done many things, and they are very, very effective, our people. That is our fellow that was involved in our transplantation in Iran, you know. That is everyone they know about the transplantation something. Perhaps not good experience everyone, but we have we have about 200 center for 20 center for the transplantation that there are yet enough experience to do transplantation. Thank you very much for everybody, and good luck for everything. Bye-bye.
Yes, thank you very much for the information. It's yeah, actually I didn't know any of this, so it was all new to me, and it's good. It's good. You know, I learned a lot of things from this interactive seminar. One thing that I suggest, maybe you are already doing this, but either a national online database or at least you know, among a couple of centers or one center where you collect the you know, demographic outcomes, this information, you know, who got transplant from what disease, some sort of a combined database, so that you can look. I mean, it's a huge number of transplants that you've done, that you can just look back and query the software and say, okay, I'm interested in you know, analyzing whatever, I don't know, thalassemia between this year and that year, who got myeloablation from an unrelated donor, and then it generates the data, and a fellow looks at it, and statistician analyze it and publish the data, because these are really large numbers, very, very large numbers, but it does need a nicely audited and maintained database. I don't know, you might already have it.
Thank you very much. We have done before I retired. We have done for national. We collected, but not for the randomized study or for the multicentric study. You know, that is. But we are now in the society, bone marrow transplantation society. That is what your suggestion. We can perform perhaps this your suggestion to do this multicentric and collected the data for the publication. Thank you very much.
Thank you. As Professor Kavamzadeh mentioned, we recently published our data regarding haplotransplant. We had about more than 120 patients with haploidentical transplant from 2010 to 2019 only for acute leukemia, and also more than 100 unrelated transplant only for acute leukemia. And interestingly, we used the combination of ATG and post-transplant cyclophosphamide, but with modified dose of post-transplant cyclophosphamide in the context of myeloablative conditioning regime and peripheral blood stem cell for almost of our patients.
Very nice. Well, congratulations. I see one hand raised here. I only see the first name, Mohammed. I don't know if the question was read or not.
Yes, can you hear me, Dr. Rashidi?
Yes, yes.
I wanted to thank you for your great presentation. And I wanted to ask you a question about what is your opinion about immunomodulators such as thalidomide or lenalidomide in treatment of acute GVHD? And also, have you, of course, you have heard about fecal microbiota transplants. What's your opinion about that in acute GVHD? It had very impressive results.
Yes, so thalidomide, lenalidomide, I really don't know anything about them in the setting of GVHD, other than I know there was a trial of lenalidomide for, I think it was for as maintenance in myeloma patients after allograft, and it just caused a lot of GVHD. And then I heard from a senior physician several years ago that the timing of these immunomodulators after transplant is so important, because at least in animal studies, if you do it just a day or two too early or late, it can cause bad GVHD. But I think your question is how to treat GVHD with this. I have no idea really. I've never seen any literature. I've never tried it myself. Maybe there is something out there. To your other question, yes, definitely. I didn't want to put anything that's still considered experimental, even though it might be very attractive in these slides, just because this was supposed to be mostly standard of care and educational. But with the role of microbiota being more explored in recent work and fecal microbiota transplantation, there are now maybe 6 or 7 papers that tried FMT to treat steroid refractory GVHD. The Japanese study maybe 3-4 years ago with 3 patients looked very encouraging. And then the Dutch experience was published, I think, a few months ago in Blood Advances. And so, yes, definitely, I think there is room to improve there. The question is, can we do it without, like as standard option? Can we just do it for a patient? The logistics of this procedure are not easy. The old way of just putting the stool sample in a bag and feeding it by an NG tube is really not the right way of doing it. I think it's just too, unappealing to patients. And then the other aspect is, well, if you want to encapsulate it, is there a manufacturing facility that extracts, gets rid of the larger particles in the stool and put the rest in medical capsules that don't smell, don't taste, and then making sure that these are enteric coated so they open up only when they reach the small intestine or colon, not earlier on in the stomach or esophagus. So it is quite a bit of challenge how to make this happen safely and comfortably. And then if you want to use it as enema, is it safe to do in a very neutropenic patient? How do you You know, do you want to do it just once? Do you want to do it several times? And I think the most important question actually in using FMT for treatment is these patients are on antibiotics. How do we want to save the microbes in the FMT from those antibiotics? Well, the Japanese study actually, or other studies, continued the antibiotic, but it's a question, right? Will the same antibiotics not kill the beneficial anaerobes or commensal bacteria that we are transferring? Then what are we doing with that? And more critically is the question of what if with Cipro or whatever antibiotic we're giving, we actually cause or promote the growth of resistant bacteria that some healthy individuals might have in their stool. So can we cause ESBL bacteremia by giving antibiotics while patients are also on FMT? You know, this is what happened in the I think in one of the publications, it was in New England Journal of Medicine last year, that ESBL E. coli that caused death and bacteremia in a patient, they could trace it all the way back to the FMT product. So is there a facility to screen the stool samples and make sure none of these antibiotic resistant genes are present? What if the stool sample has COVID in it? You know, it's a new question. If you get it from a considered healthy donor, what if that healthy donor had COVID two weeks ago? Can COVID be in the stool? Can you find it? So there are just a lot of safety and logistic challenges. We are doing in our center a trial of FMT. These are encapsulated FMT, 5 pills that we give leukemia patients and transallograft patients, and we do it up to 3 times, but it's under so heavy scrutiny by FDA and IRB, and there's just a lot of care that we need to take to make sure we don't cause harm by these approaches. And at the end of the day, until there is a randomized trial showing clinical efficacy, we're not going to know if improving the microbiota is necessarily associated with better outcomes. You can, yes, the trials that have been published, they fixed the microbiota problems, they added commensals, they improved diversity, but it doesn't matter for the patient. Does it result in clinical improvement? So more questions than answers. This is such a novel, field. It's really infancy right now.
Thank you.
Thank you. Any question? Thank you. Many thanks from Dr. Rashidi for your practical lecture. Thank you for all of participants. Thank you and bye.
Thank you for inviting me. Have a great day.
Thank you.